Gastric peroral endoscopic pyloromyotomy versus gastric electrical stimulation in the treatment of refractory gastroparesis, a propensity score-matched analysis of long-term outcomes. Introduction. Gastroparesis is a chronic morbid motility disorder of the stomach and is a syndrome characterized by delayed gastric emptying in the absence of any mechanical obstruction. Pharmacotherapy of patients with gastroparesis is often not very effective, with less than a third of patients showing clinical improvement after a year or longer on medical treatment. Therefore, the treatment of gastroparesis remains quite challenging. Gastric electrical stimulation, GES, has been introduced as a treatment option for medically refractory gastroparesis. Some open-label studies reported one-year clinical response rates varying from 45% to 74%, with only a quarter of the initial patients maintaining a response at 3 years. This invasive approach can be complicated by implantation site pain, infection, dislodgement, and skin erosion, and is associated with a removal rate of 6.3% to 12.8%. As a pyloric-directed therapy and less invasive technique, gastric peroral endoscopic pyloromyotomy, GPOEM, also known as peroral pyloromyotomy, is becoming a promising treatment option for refractory gastroparesis. Several trials have shown that GPOEM led to a one-year clinical response rate of 57% to 85%. The effectiveness of GPOEM has also been observed for patients in whom GES failed. Given the promising outcomes and less invasive nature of GPOEM, Shen et al. Hypothesized that GPOEM is superior to GES in the treatment of patients with refractory gastroparesis. The authors conducted this study to compare the long-term effectiveness of GPOEM with that of GES in patients with refractory gastroparesis. Background. Gastric peroral endoscopic pyloromyotomy, GPOEM, and gastric electrical stimulation, GES, have been reported as treatment options for refractory gastroparesis. In this study, the authors compared the long-term clinical outcomes of GPOEM versus GES in the treatment of such patients. Methods. Shen et al. Retrospectively evaluated 111 consecutive patients with refractory gastroparesis between January 2009 and August 2018. To overcome selection bias, they used propensity score matching 1-to-1 between GPOEM and GES treatment. The primary outcome was the duration of clinical response. Results. After propensity score matching, 23 patients were included in each group. After a median follow-up of 27.7 months, GPOEM had a significantly better and longer clinical response than GES, hazard ratio HR, for clinical recurrence 0.39, 95% confidence interval, CI, 0.16 to 0.95, p equals 0.04. The median duration of response was 25.4 months, 95% CI, 8.7 to 42.0 in the GES group and was not reached in the GPOEM group. The Kaplan-Meier estimate of 24-month clinical response rate was 76.6% with GPOEM versus 53.7% with GES. GES appeared to have little effect on idiopathic gastroparesis. HR for recurrence with GPOEM versus GES 0.35, 95% CI, 0.13 to 0.95, p equals 0.05. The incidence of adverse events was higher in the GES group, 26.1% versus 4.3%, p equals 0.10. Conclusion. Among patients with refractory gastroparesis, clinical response was better and lasted longer with GPOEM than with GES. The positive outcomes with GPOEM are likely to derive from the superior clinical response in patients with idiopathic gastroparesis. Further studies are needed to confirm these findings.